Okay, so welcome everyone to our behavioral support rounds. The title of today's rounds is Lessons from the Pandemic, Finding Resilience and Strength Through Meaningful Engagement. The session is co-hosted by myself, Stacey, and Inat. I'm a knowledge broker with the Ontario Centres for Learning, Research and Innovation in Long-Term Care. And Inat is the BOT Clinical Manager, Behaviour Support Procedure Program at Dupuis. Just some technical issues. I can't seem to advance my slide.
Hey, Stacey, what if can you advance it from the keyboard and just press the arrow buttons?
Yes.
There we go.
Thank you, Agnes. Thanks for everyone bearing with us. Okay, so before we start, although we are meeting virtually, we acknowledge that BayCrest and our related Toronto Central Network behaviour support systems operates on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the Dish with One Stone Wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. I would like to amplify Perry Bellegarde, the outgoing National Chief of the Assembly of First Nations, words. I think Canadians are embracing the fact that we need to have transformative change, but we can only do that together. I'd like to acknowledge that Rounds is supported in part with funding from the Government of Ontario through the Ontario Centre for Learning, Research and Innovation in Long-Term Care, the Behaviour Supports with News Program, and the Toronto Central Local Health Education Network. And that the views expressed herein do not necessarily reflect the views of the province. I'd like to review the format and participation guidelines for today. We appreciate the transition to the new platform will take some time to get comfortable with for us as well as you. We will have 40 minutes of presentation followed by 15 minutes of discussion and a wrap up. The session is being recorded and it will be as usual archived on the Ontario CLRI website and the BSO website. Your microphone is automatically muted, but you are able to unmute during the discussion, and please contribute to the discussion in the Q&A session. If you could place any questions that you have in the chat, and you can choose to chat with the full attendee list. If you have any questions related to tech support, the organizer would be the person to contact there, and we will help you out. And for those of you who are interested in receiving a certificate of attendance, just please remember to complete the evaluation that is sent via email at the end of this rounds. Okay, so over to Inat.
Thank you so much, Stacey. Our topic for today is lessons learned from the pandemic, finding resilience and strength through meaningful engagement, which I think is really a great time at this summer season to stop and reflect on those topics. I would like to welcome our speakers. Dr. Kate Dupuis is a Schlegel Innovation Leader in Arts and Aging at the Sheridan Center for Elder Research in Oakville, Ontario, and a registered clinical neuropsychologist who specializes in working with older adults and those who care for them. After completing her PhD in cognitive psychology at the University of Toronto, Kate was a postdoctoral fellow in their neuropsychology and cognitive health and hearing services programs at Baycrest Health Sciences. In her work, Kate uses both quantitative and qualitative methodologies to explore how to improve the overall health and well-being of older individuals and their care partners, with a particular focus on identifying and addressing potential barriers, like, for example, hearing loss, cognitive impairment, self-perceptions of creativity, into both active and passive arts participation. Dr. Ellen Power is a geriatrician and a Schlegel Chair in Aging and Dementia Innovation at the Schlegel University of Waterloo Research Institute for Aging in Ontario, Canada. He is also Clinical Associate Professor of Medicine at the University of Rochester, New York, and an international educator on transformational models of care for older adults, particularly those living with changing cognitive abilities. Dr. Powers is the author of two well-regarded books, Dementia Beyond Drugs, Changing the Culture of Care, and Dementia Beyond Disease, Enhancing Well-Being. Dr. Power also has a 20+ year history working in culture change, having led St. John's Home in Rochester to become the world's largest alternative member home. He also helped develop St. John's Penfield greenhouse homes, and the only community integrated greenhouse homes in the US. And he is currently working with Dr. Jennifer Carson on a new book about creating inclusive communities for people living with dementia. And all of that expertise coming out of both of our speakers to really inform the fascinating topic that we have for today. I have also watched a YouTube where this topic was shared by Dr. Power and Dr. Dupuis. And I'm so excited that they're here to share with us this fascinating talk today and their insights from the pandemic and how those insights have transformed the care provision and recreational and engagement in long-term care homes. So Dr. Dupuis and Dr. Powell, the stage is yours. Thank you again for being with us today.
Okay, thanks very much, Anna, for that. Kate is going to run our slides for us, and she is the meaningful engagement expert. And so what I'm going to do is just make a few framing comments to start this off for a few minutes, and then turn it over to her so she can talk about the research and the engagement that she has been doing over the past 1+ years during this difficult time. Part of the reason that I'm going to talk about this is Anna mentioned my work in culture change. You might wonder, with what's been going on for the past 1.5 years, well, why are we talking about meaningful engagement? Is it possible, those who hear about culture change or that quote that Stacy read about transformation, is that possible in a pandemic era? You know, is culture change dead because of medical emergencies like this? So I wanted to just give you a few comments about really where I think this fits and how I think this actually is an imperative, not just something that we can continue to work on. So Kate, if you could go to the first slide there. Some of the questions I think that, I'm sorry, the next slide there. Some of the questions that may come out in this age of pandemics is, will our experience with COVID turn our long-term care homes back into mini hospitals? And can this idea of culture change, which I quickly define as shifting from an institutional model of care to a more social relational model of living, can that move forward in a post-COVID world? And what Kate will address for us too, is it possible to meaningfully engage people and to counteract the harmful effects of social isolation that have come about with all of these infection control restrictions. So I've been doing a little work, and if you can go to the next slide, please. Jennifer Carson and I have also written a paper which is tentatively going to be published in a special edition next January in the Healthcare Management Forum, where we looked at some of the risk factors and looked at the issue of culture change. Is it dead or is it not? And just a little bit about the Canadian experience. First of all, there are over 55,000 infections as of mid-June and 15,000 deaths in long-term care of long-term care residents. That represented nearly 60% of all Canadian deaths due to COVID. And the risks certainly resulted directly from a lot of infection control issues, but also came indirectly from other operational and infrastructural issues that have been gradually being identified. Some key risk factors affected all long-term care homes pretty much equally across the board, but there were others that were very variable, where different homes had very different experiences. So the question I want to ask here is, what were some of the differentiating factors? The next slide just talks about some of the universal experiences, universally felt systemic failings, and some of the things that, in particular, the Ontario Long-Term Care Commission and CIHI and other people have identified. A lack of pandemic preparedness, expired stockpiles of supplies that were not replenished before the pandemic, lack of personal protective equipment and testing supplies, inadequate understanding of the modes of transmission early on, so universal masking didn't happen right away when the pandemic came to Canada. Difficulties with that interface between acute care and long-term care, the prevalence of infection in the surrounding community, and perhaps some missteps at the governmental levels too. These have all been identified, and these have been really focused on by the Commission. And they are certainly all real and very important, but I think you could argue that probably most long-term care homes across the province, across the country, have been affected by these fairly equally. These are not regional or specific to one particular model of care. But the next slide shows some differentiating factors, which have also been identified by various studies in Canada or around the world. And these are some risk factors that have been shown in research over the past year and a half to have been risk factors for COVID infection, outbreaks, and COVID deaths. First of all, large buildings and crowded living areas. In Brown et al. Recent paper in JAMDA, which our colleague Andrew Costa was part of. Multi-bedded rooms was part of that too. And that study looked at 618 Ontario long-term care homes. And they came up with the astounding calculation that if those homes had changed all of their multi-bed rooms to single rooms, private rooms, before the pandemic started, they would have prevented 30% of their deaths. So that's really huge. Crowded common areas, rotating staff, more people coming into the area, bringing in infection, and along with that, high agency usage. So people coming in that don't normally come into the home. And once again, when you work in multiple different areas, you're more likely to be exposed to people who may be infectious. Inadequate sick leave was also correlated in an English study with increased risk of infection because people were working when they weren't feeling well instead of taking personal time that was not paid. It was also found that there was a lack of full-time positions working in one home, so you had to work multiple jobs in different locations. That was a risk factor. And lack of access to outdoor space appears to be a risk factor as well. It's interesting to me that all of these factors that were differentiating risk factors have been part of the core message of the culture change movement for over 2 decades. And so I think that we have to question, is really moving to the mini hospital model the right move for long-term care after this? So I want to highlight one particular study, which has been the most striking one to come out of the pandemic so far, and that is of the greenhouse model. The greenhouse model is a small house model, which has started in the US, but there's been some Canadian interest, and we just had a presentation that was organized in June. And so there may be some people looking at moving this model to Canada. They are small houses, usually of 9 to 12 residents. Everybody has a private room with an ensuite washroom and shower. There are central open floor plans rather than the long double-loaded corridors. Everybody has direct access to an outdoor space. And so they looked at nearly 300 small homes following this model. And once again, these are some of the things that are sort of the non-negotiables of the model. In addition to what I mentioned there, if you look down the list, almost all of them have consistently assigned team members. There's rare to no agency use in this model. The pay is higher because we have versatile trained staff, so they're not just doing PSW work, but they're also cooking, sharing meals with people, doing some basic activities and house management skills, along with support from the clinical staff. And so better benefits and the quality of life and staff retention have been long proven to be superior to traditional long-term care. I think the versatile training of staffing is also important, and there was just something that came out today on one of our long-term care media outlets, McKnight's, talking about a study that David Grabowski and one of my colleagues at the University of Rochester are doing, where they're showing that the more people come into a space, the greater risk of transmittal of infection. So once again, when you have a person who can do the personal support worker work as well as doing some of the dining and activities and household management and housekeeping skills, then you're cutting down that as well. And once again, the open floor plan and the physical structure is very important. What the study found, going to the next slide, is pretty striking. And that is that, oh, I'm sorry, I didn't show it. Okay, I guess I don't have a slide for that. So before I go to the summary, what the study found was that the deaths were only a small fraction. And they had such a small number of deaths that they had to calculate deaths by deaths per 100 resident years. In other words, 100 residents living for a year to find anything. And even then, the greenhouses overall ranked 0 in deaths per 100 resident years. And even when they took the top quartile, the top 25%, it was only about 1 or 2 deaths compared to about 10 or 15, depending on the large or small comparison traditional homes. So really huge. The death rate at one point during the study was somewhere in the range of 25 times as high in traditional long-term care as it was in the greenhouse households. So this really throws into question the wisdom that we need to be more about like a hospital in our long-term care homes, because even though infection control is a big issue, many of these other operational factors, staffing factors, and structural factors actually were equally responsible for outbreaks and deaths. So just to summarize my little part here on the next slide, first of all, a successful pandemic is more than just the mechanics of infection control. It's more about hand washing and gowns and masks. The differentiating factors in long-term care were actually mostly related to operational, staffing, and structural factors. So ironically, one of the models of care that has moved farthest from a medical model has been the best evidence for success during a pandemic. And that means, in other words, culture change is also good infection control. So I think that's just something to encourage us. We've certainly been having a little existential crisis saying, is all this work we've been doing really valid? Is it out the window? But I think it shows that it is very much valid and even an imperative to change long-term care, as Stacy said in the quote she read. So my last slide here just makes a transition to Kate. And that is, it's impossible to support individual well-being inside or outside of pandemics if you have rigid hierarchical systems of care and long-term care policy. And once again, the effects of isolation due to quarantine and what that did to create excess harm to our residents is a great example of that. Meaningful engagement requires a lot of flexibility, creativity, and individualized approaches. So I'm going to turn it over to my colleague, and Kate, I'll let you take it from there. Thanks, everybody.
Thank you so much, Al. It seems like it was quite a long time ago when we first started talking about this presentation today. I think it was a lot colder back then, but I was really excited to partner with you for this opportunity, because we had just been really grappling with a lot of these questions that you were having. You know, is meaningful engagement possible? What is happening within the long-term care space? And so I'm happy today to be able to present some data that we've been collecting over, I guess, almost the past 9 months here today. So as Al discussed a little bit, obviously within the initial response to the COVID-19 pandemic, there was a huge amount of change in terms of infection prevention and control, restrictions both into long-term care homes and also within the spaces themselves. So for example, very early on in April of last year, people who were working in multiple homes were restricted to just one home. So that would impact things like your music therapist, horticultural therapists, pet therapists. It also meant that family members necessarily weren't able to come into the homes. Within the spaces themselves, individuals were often cohorted into small groups, or even if a home was under outbreak, restricted to their own room for an extended period of time. And one of the questions that came out of my own work, which of course sort of ground to a halt very quickly, was, is it possible for us to engage residents and counteract these harmful effects of social isolation? And within the long-term care space, who is it exactly who would have the opportunity to provide these exercises, these activities that can benefit not only the physical well-being of residents, which of course was sort of the number one concern very early on, but multiple domains of well-being. So cognitive engagement, social engagement, mental health, spiritual care. Who is the one really within the space who is able to provide a lot of this for residents? And that work seemed to be falling quite heavily on therapeutic recreation. And so in my own research at the intersection of arts, health, and aging, I work a lot with the therapeutic recreation teams within long-term care, because that's where a lot of arts-based programming and arts-based activities are happening. So it really seemed like a natural fit for me to delve into this a little bit deeper and find out what is actually happening within the therapeutic recreation space in long-term care. And within my own work, of course, I had put my research on hold, but I was still in touch with a lot of my colleagues within the Schlegel villages in particular. And so listening to these lived experiences of staff, so starting to try and understand their perspective of the rapid emergency responses, the modifications that they had to make to activities, and really starting to question, just like Al was discussing, sort of, I guess, how and even is meaningful engagement continuing? You know, we saw a lot of these images early on in the pandemic of people making beautiful windows and lovely displays so that if family members were coming for outdoor visits, they had something gorgeous to look at. All of this type of work was falling oftentimes to those working within the recreation space in order to try and engage residents with their loved ones, with friends, both in and outside of the home in a meaningful way. And so this picture is quite blurry, and the reason for that is I was running an intergenerational music therapy intervention. Gratefully, we are funded for that through CAVI, and I had asked one of the team members at our village in Waterloo to take a photo from her end, so I could see out from the screen, but I couldn't see what the space looked like for the residents. And so in this photo that she sent me, she actually inadvertently captured their signboard that was telling residents what the activities were for the day. And of course, recreation calendars are not the be all and end all when it comes to meaningful and purposeful activities for residents within this space, but they are often quite good representations of what is being offered in terms of engagement. And what I really was struck by is this idea that on this particular Thursday in October, which was sort of the height of wave 2, was starting up here in Ontario, we really just were offering at this particular time 3 opportunities to residents: morning baking, video calls, and then an afternoon happy hour. And even the video calls, you can think to yourself, well, how many people are actually being engaged in that activity? It has to do with how many staff are available to run iPads or computers, how many computers and iPads are available. So thinking of, in a neighborhood with 30 to 40 residents, how many folks are actually getting to engage in activities with other people, be it in person or virtually, it's probably quite limited. And so this really struck me and sort of started me down this path of looking into, how are we being able to provide these types of meaningful experiences for our residents within long-term care, not only in Ontario, but really across the country. And in some of my work, I have looked at these recreation calendars. And so what I was able to pull up was actually a calendar from one of our villages from a January calendar back in 2017, and then a January calendar just this past January. And so what you can see is on sort of a month of Saturdays, quite different experience, right? So Al had mentioned staffing was quite an issue and continues to be quite an issue now within the long-term care sector. I'm assuming that on our Saturdays in 2021, on those 3 Saturdays where you really don't see a lot of activities at all available for residents, there probably wasn't a staff member who was available to provide those activities. So when we think of engagement, before and after, or before and during the pandemic, there did seem to be quite a change, and it was really something that we wanted to investigate further. We also know that from sort of the general media and from the research literature itself, there's a very limited focus on recreation during COVID-19. And obviously the focus had to be right from the start on physical health and well-being, absolutely. But as I always tell my students, in a 24-hour day, if on average in Ontario, you get 2.75 hours of personal care and then maybe a few hours of dietary assistance, and you're sleeping for a number of hours, you probably have about an 8-hour, so a typical work day, that's available to you. And in the pre-pandemic times, that would be filled with recreation activities. And so there's been a lot within the research literature around social isolation, increased cognitive issues, increased personal expressions or responsive behaviors of residents, especially those who are living with cognitive challenges. And so trying to make this link between, well, perhaps, a lack of meaningful engagement for residents is actually directly linked to the types of changes that we're seeing in many residents. And concern not only for the mental health of residents, but also of those who are providing care. So the Long-Term Care Commission report that came out in April that Al referenced earlier did specifically indicate that licensees should provide free counseling for staff, understanding that this particular experience has actually been quite traumatic for many individuals working within the homes. And I'm sure you've all seen these types of headlines, talking about the trauma, the PTSD, the burnout that's being experienced. Oftentimes when you see these types of headlines and you read into the articles, they're typically focused more on those folks who are providing the personal and physical care to residents, so nurses, physicians, PSWs in particular. There hasn't really been a lot of focus on therapeutic recreation and those providing recreation care. And one of the things that myself and a colleague, our Schlegel spirituality specialist, Dr. Jane Kipfer, and I have been looking at is really this idea of the trauma that is being experienced by those working in long-term care, but specifically those working in that recreation space, and how that may be leading to feelings of moral distress and even in more serious cases, moral injury. And these terms are developed primarily in a military context, but more and more of the literature is trying to suggest that during COVID, these can actually be put forward for those working in a healthcare space. And so the idea here is really, if you have a moral belief about the type of care provision that you are comfortable and hope to be able to provide to people, so for example, to your resident in long-term care, and you're being stymied from being able to do that, likely because of systemic barriers due to infection control, that can actually cause quite a mismatch between what you're wanting to do and what you're able to do, which can lead to moral distress, and moral distress can lead to burnout, leaving the sector. And of course, we're starting to hear stories of nursing shortages, PSW shortages, and thinking of that from the idea of how are we providing meaningful engagement for residents, wanting to protect our staff and find out a little bit more about how they're doing. And so for our own work, it was really looking at how can we support those working in the therapeutic recreation space moving forward. Well, we can't support them if we don't know what's happening. So we have to learn more and we have to try and share. So opportunities such as this one, I recently gave a keynote speech at the Therapeutic Recreation Ontario annual conference. So just trying to advocate for the sector and let people know that they're not alone and their efforts to provide meaningful engagement are being seen. So we created a short survey that was launched at the end of October of last year and continued until the end of February. And this is actually probably a really good time because in most of Canada, it's cold during this time. So things like virtual family visits, outside programming was pretty much absent. We also had the holiday period for many individuals, which is often a very emotional time in general. This was the first time it happened during a pandemic. So we were also able to capture some data around what team members were doing in terms of meaningful engagement for individuals of different faith-based or religious backgrounds. So we tried to keep it as short as possible, being mindful of what is going on in staff lives and not wanting to ask them to spend too much of their time to do this. So we had a number of demographic questions and then some more open-ended questions related to the changing role during COVID and their own experiences. It was all anonymous. They accessed it simply through a SurveyMonkey link, which was gratefully shared through the CLRI, through the RIA, through my own center at Sheridan, through Therapeutic Recreation Ontario, and also through a number of social media channels. And so we ended up with over 430 responses, and I'll be discussing today data that come from 299 respondents working specifically in long-term care. We also had some individuals who are working in retirement spaces, but we really just wanted today to focus on long-term care, given our audience. Not surprisingly, given the typically gendered roles that we see often in the long-term care sector, the majority of our respondents were female. Mean age was 38 with quite a large range, as you can see. And the median time in roles was approximately 3 years. That doesn't necessarily mean that is the time in the sector, but within that recreation role, that's around how much time people had been in. And again, you can see a huge range. We hit people who had literally just joined the workforce and people who'd been there for 3 decades. We had responses from 113 unique operators from across Canada. We have 6 responses from 6 provinces and 2 territories. And the majority of responses did come from Ontario, likely due to the fact that we're all based in Ontario and a lot of the recruitment that was happening was from Ontario. But we were pretty surprised that we got quite a bit of response from other parts of the country. So going back to that idea of sort of, who is providing this meaningful engagement and how are those people doing? We wanted to see how individuals were coping both physically and emotionally with the pandemic. And what you can see is that in general, people rated themselves in pretty good physical health, but then there was actually a significant difference then for people rating them their own mental or emotional well-being, where we had a lot more people rating themselves at the low end of the scale. And so this, I think, probably factors into those questions of moral distress and moral injury and burnout. If you're going through months and months and months of time where you're not able to cope emotionally with what's happening, and it's just such a barrage of difficult experiences, and you can see probably why moral distress and moral injury is something to be concerned about within this space. We asked staff to comment on their job satisfaction, and again, not surprisingly, the vast majority of them did indicate that there was a decrease in their job satisfaction, and this is, again, probably not anything that's mind-blowing to those listening, but it's important for us to actually gather these data and to be able to have the numbers to support, these individuals getting the help that they need moving forward, especially if we want to encourage them to stay within the sector. And a lot of these changes, these negative changes, had to do with concerns about getting COVID or bringing COVID. This idea, again, of residents falling through the cracks, so not enough time in the day. So again, that idea of the moral distress of I want to be with people, I want to help them and provide them with those meaningfully engaging activities, but I just physically can't because there's just one of me. I love what I do, but the restrictions and barriers are overwhelming. We did have a number of people who pretty much stayed the same. They said, no change, some days are good, some days are bad, but it was like that pre-pandemic anyway. And then we did have a small percentage of our respondents who said that their job satisfaction actually increased during the pandemic, which is really nice. A lot of the residents spoke to the fact that they were the resident's person. If a spouse or an adult child couldn't come in to visit, they were the ones who were there for them. And that connection was so important and made them feel so positive and, made them feel like they were making a good difference in the lives of their residents. So I'm going to go talk about very briefly some major changes to roles in terms of recreation and how those working in the therapeutic recreation space were able to overcome with those creativity and innovation ideas that Al had mentioned earlier, how they were able to overcome these challenges to try and provide those activities and opportunities for meaningful engagement to those living in long-term care. So programming clearly had to change. We can't have a group of 30 people in a room singing together. So more one-on-one activities, small groups. I know one of our directors of rec at one of our homes in Waterloo would have, a room of 4 residents next to another room of 4 residents because you could only have 5 people in a room, and then she would be running back and forth between rooms so that there'd only be, a maximum of 5 in each room. This takes a lot of time. This takes a lot of effort. Novel use of space. So really any wider open space was being used, and Al had referenced that a little bit before in terms of, how are we actually providing programming? So you saw a lot of people were using the hallway. So residents would each be sitting in their doorway with the door open and then singing together, with their PPE, with their mask on, singing together down the hallway. They would oftentimes be doing, out on the balcony. There'd be, say, a performance down in the driveway, and residents would come out on their balconies to watch. So really trying to be as creative as possible in order to offer those engaging opportunities for folks. Traveling cart programs are really popular. Sometimes carts would probably be really fun for happy hour as well. We saw those where, the residents would be in their rooms, possibly cohorted or possibly even just alone, and then the staff would be going up and down the halls providing them with activities. A lot of drop off, so a lot of staff would say things like, I would drop off some laundry to be sorted for a resident from sort of a Montessori perspective, or drop off Sudoku crosswords that could then be collected later on. And of course, all of this requires a lot more repetition than before, and a lot more cleaning, of course, and a lot more purchasing. So I had one participant who said, at the end of the day, I'm off to the dollar store because I need another 20 kits to do painting with. Whereas before, everyone could share the same paints. Now you have to have the exact same kit 20 times because you don't necessarily want to be washing everything right after. It's so time consuming. It's just easier to have multiples of everything. So I assume that a lot of recreation teams within long-term care will now have really well stocked, art bins and things like that, because they had to be careful in terms of an infection prevention control perspective. Visits were something that really took on a life of their own and really started to take over programming time. So virtual visits or in-person visits, be they indoors, outdoors, through a window. A lot of the respondents were saying, we had to learn all sorts of new technologies in order to be able to ensure that, and not only teaching themselves the technologies, but teaching family members and loved ones outside of the home the technology. So you'd have to call, walk someone through setting up Zoom, then set up a Zoom call, have the Zoom call. All of this is incredibly time consuming and of course takes away to some extent from the programming, which is likely why we saw that example of a Thursday in October where there were 3 activities, because just to set up that 10 o'clock video call would probably take a few hours of time liaising with family members and friends in order to be able to, set up the schedule. Masking residents, cleaning after visits, portering to and from the outdoors. I know at Baycrest, there was a lot of portering that was being done by other professions within the homes. So all of this, is again time consuming and needs to be done in order to provide those engaging opportunities. A lot of the respondents said, now basically the primary function of my role is connecting residents and their loved ones. I don't really have time for programming. I'm mostly facilitating visits and trying to take advantage of any opportunity you have to connect residents, to be able to have those socially engaging opportunities, always keeping in the back of your mind the risk of social isolation for residents during this time. As I mentioned, technology became a huge concern. Many homes had to quickly buy technology, boost their Wi-Fi signals, which, I know from my own visits to homes aren't necessarily good all over the buildings. And then also do a lot of learning about programming through technology. So virtual music concerts, virtual visits, not only from family and friends, but, for example, the pet therapist would Zoom into the home virtually, or watching performances, a lot of arts-based activities that can be offered sort of from a passive perspective of observation over Zoom or over YouTube, for example. So that, of course, then requires a lot more time spent searching for these things and trying to find good resources. I know that CLRI came out with a great resource for arts-based activities during this time, and so many, within my own work, I looked into how so many arts organizations transitioned a lot of their programming online. So there was a lot of opportunities, but you had to make sure that you were on the ball and finding them and which link to use. Again, all of this is really all about engaging residents and making sure that all the domains of their well-being were being activated. Different forms of communication present their own learning curves, not only for staff, but also for loved ones. Some staff were working from home for the first time, which they had never really had the opportunity to do before. Purchasing technology or just not having enough technology to go around, ensuring that technology was being sanitized before being shared. All of these things were extra steps in order to engage residents. Staffing, which is not an issue specific to recreation, of course, that we're seeing it across the sector, was absolutely something that was described in terms of a barrier to providing these types of opportunities. So there's just so many tasks that weren't necessarily related to recreation that were being placed on the backs of recreation. There was a lot of dietary and mealtime support. So I know at one of our homes in Guelph, our past director of rec would typically try and do 1 meal a day within the dining room just to be around the residents and ensure that everything was going smoothly. And now is taking 2 meals a day, which is a lot of, double the work for mealtime, and then you have half the time for programming and planning. So we saw that a lot, that that sort of immediate response to dietary assistance, of course, was so necessary because you didn't necessarily have the people there on the ground to be able to do that. So recreation was being pulled into that space. A lot of time spent on PPE and cleaning. We found that a lot of the recreation staff were the ones doing screening, and screening not only of residents and visitors, but also of other staff members themselves. And so that, of course, takes away from programming and isn't really, when you're doing, the screening at the front doors, then you don't necessarily have an opportunity to be engaging with residents. So oftentimes the staff would be trying to set up something on a screen, for example, or have an opportunity available for residents to be engaging with sort of passively while they themselves were doing another activity. And having to support residents to follow the rapidly changing rules, right? It was like every week there was something new coming down, the new measures, new restrictions. When staff said, I feel like I'm just not there to have fun and entertain and connect with the residents anymore. I'm kind of the mask police. No, you can't hug that person. You must put your mask on. You have to wash your hands. And a lot of, the role was around sort of talking to people not necessarily about the engaging activities, but about the rules, which again is a shift and a departure that so many staff within the sector had to do. But in particular, recreation was indicating that that was something they definitely noticed. And of course, this is not necessarily specific to pandemic times, but not enough time, not enough resources, not enough space. You know, especially when you used to have a large room of 20 to 30 residents, how do you break that down into small groups of 5 people? You might just not have enough physical rooms to be able to do that in. And then not being able to help residents. That was really a concern that came up over and over again. And I believe will tie into that idea of sort of the moral distress and injury that, you know, residents are lonely in their rooms. There's only one of me and 32 of them. And in the past, maybe all 32 could have been together, or at least 16 could have been together. But now if you're restricted to one-on-one programming with residents, it's really, really difficult. Resident morale has been down. You know, they're lonely, they're not being able to see their family in person, and the therapeutic recreation staff had no control over that. And so having to go into work every day knowing that, again, today you're going to have to tell a resident, I'm sorry, you know, so-and-so can't visit, or I'm sorry, you can't go visit your friend down the hall, you have to stay in your room. Just very distressing for staff to experience. Of course, it came, you know, there was a lot of this was coming from a place of infection prevention and control. So making sure, you know, who's able to come into the home and what do we have to clean or provide to people when they are coming into the home. There's also concerns about lack of support from other workers within the space and leadership and the value that's placed on the role. So one individual said, you know, recreation was the first to go. Programs were discontinued. We were shuttled off into screening and into dietary assistance, and perhaps there's not a great enough understanding that therapeutic recreation is mandated in the Long-Term Care Homes Act, and residents must legally have access to meaningful and purposeful activities to engage that all the domains of well-being every day. And so, you know, using these data to try and advocate for that a little bit more. Now, of course, the effects of the pandemic aren't necessarily just on the staff when they're within the home, right? It can also impact them when they go home as well at the end of the day. So we did see a lot of discussion around fatigue and mood. So I'm tired at the end of the day. You know, this is taking a toll on my mental health. I experience anxiety more. So really having to be concerned not only about the mental health of the residents, social isolation, loneliness, lack of meaningful engagement for residents, but also what this was doing to the staff as well. And as I mentioned earlier, you know, the Long-Term Care Commission does recommend counseling. The Ontario Psychological Association did have some free services available to those working in healthcare during the pandemic, and actually in our debriefing at the end of the survey we mentioned that information. So if anyone really was struggling, I actually gave them, you know, the contact information so that they could hopefully access some resources to support them going forward. But you know, this is something I'm sure people will be grappling with throughout the pandemic and after as well. Work-life balance for parents. This one really struck me because I'm a parent to 2 small children, and one of them has been in my house for too long. But this idea, you know, that therapeutic recreation typically happens in an 8-hour shift in a home in long-term care. And during the pandemic, many therapeutic recreation staff were actually having to be working from home and maybe managing that virtual schooling, or having to miss work because their kids had symptoms from school. And so they were having to stay home to get the kids tested, or, you know, stay home for the 14 days. Some residents on medical leave because of personal reasons, pregnancy. So a lot of things that, you know, are just sort of bubbling up and making it more difficult for the staff to be in the home and to be providing these meaningful engagement opportunities for residents. Concerns around housing and finances. I mean, we recently heard that there will be a $3 pay bump for PSWs. We haven't really heard anything similar for therapeutic recreation. There was that pandemic pay early on that was then taken away. So, you know, one of the respondents said, I could get paid this much if I worked at McDonald's. So things like that, I think, are really important for us to consider from a sort of systemic perspective moving forward. How are we supporting the people who provide these meaningful and purposeful opportunities for residents every single day? And so I wanted to end more on a positive note and go back and reflect on what Al had said early on, which is, you know, this is also an opportunity for us to look at that culture change movement and to look at what are we doing for residents and how are we providing them with opportunities during their day to benefit all domains of well-being. And so one of the things that was very clear coming out of my data was this dichotomy. So between, yes, the restrictions to my role and the difficulties and the stress and strain, but also this immense pride, you know, like what doesn't kill you makes you stronger. Like, look at what I have been able to accomplish, even with all these restrictions and head to toe PPE. Look at the connections I'm able to make with my residents. Look at the benefits I'm able to give to the lives of the people I'm caring for. And that was just such a beautiful dichotomy to be able to see from within the data. Respondents, you know, really emphasize their own pride and appreciation of their self, their teammates, and their own abilities. So talking about flexibility, being so resilient. I know this is the buzzword of the pandemic, but this kept coming up over and over again, that staff were saying, I've never thought I'd be able to do all the things that I'm doing and manage as well as I'm able to in the midst of everything. Creativity, the strength of residents, of staff. Many staff were witness to residents getting ill, residents dying, and just their strength to continue on with their role after having seen that. Residents, I think, gave the staff a reason to feel optimistic and to go into work every day. You know, I wanted to see my resident. I had got a new item for them, you know, after work, and I couldn't wait to get in the next morning to show them this new activity that they had been asking for. Or today will be the day that a family member is finally allowed to come in back into the home. This feeling of making a difference and strengthening connections. So strengthening connections not only for the residents and their family members and friends, but also strengthening connections with the residents. So recreation staff are often the ones who are spending the most time every day with a resident. And there was a lot of indication within my data around sort of the importance that staff are placing on this, but also the privilege that they saw. You know, that I have the privilege to be with this resident every day for hours a day, getting to see them morning, noon, and night. And really being able to provide them with that meaningful connection. So one respondent said, this entire year has been one big exercise in creativity. Our role has gone from exactly what we pictured and practiced in school to something completely different, but even more important. Speaking about innovation and flexibility and creativity, this person said, I've become a church service leader, a music leader, a family member, a volunteer, a messenger, and more. We're on our own. Right? We have no religious groups, volunteers, entertainers, children's groups, etc. All of these were restricted. All of these opportunities for meaningful engagement into the home was restricted due to safety concerns. So recreation staff had to sort of step up and take this on themselves. We've always worn many hats, but during COVID, the hat rack has grown. I love that. This individual said, you know, I'm more than a recreation leader. I am an advocate. I am part of their family. So here's going back to sort of that pride in the connection that you've created with another person and in the opportunities you're giving your residents every day to have that social connection and to try and prevent the social isolation, the loneliness that we were seeing and we've all been so concerned about. And speaking to sort of pride in the role, one respondent said, you know, it's evidence that our role is more crucial and valuable than ever before, providing engagement and connection during these times. So in summary, I'd like to just highlight the innovation and strength amongst the staff who have been working in recreation and roles in long-term care. Absolutely, there were challenges within their roles, as there were in any role within the long-term care sector over the past 16 months. Issues around physical safety of yourself, your family members, your residents, concerns around mental health, constraints and demands on time, that ability to attend to and meet the needs of residents, and that sort of juxtaposition between I want to help, but maybe I just can't right now. And maybe some issues around the recognition and value placed on that particular role. But sort of in sum, and to finish off, I do want to talk more positively around, you know, this idea that we started off talking about, is it possible to provide meaningful engagement in a pandemic? The answer is absolutely yes. Within this particular group of staff working within long-term care, we are seeing incredible connections being formed and maintained, and just the personal growth and professional development of these individuals as they used flexibility, creativity, and a lot of personalization and that person-centered relational care approach to meet the needs of their residents. So thank you so much. I think we have just a little bit of time for questions, so I'll stop showing my screen.
Thank you very much for this wonderful presentation and fascinating. Those quotes were great and heartwarming. I'm sure that many long-term care staff, apart from recreational therapists, are relating to those to those comments and quotes. We do have a question from Caitlin Edwards, and she's thanking you for a wonderful presentation and is wondering how unionized strict job descriptions challenge the opportunity for all staff to feel like they have a part to play in promoting meaningful engagement for residents.
So I would say that that's absolutely an issue that we encounter, whereas, you know, there's such sort of strict siloed bins of who's supposed to be doing what within the space. That's absolutely always an issue that we encounter. And that's why, you know, I did try and say the recreation calendar, which is created by the recreation team, offers a snapshot of the engagement that's happening within a space. But clearly there's obviously other staff members within a long-term care home who can also provide those types of activities. But I do think there is sort of a sense within the homes that sort of falls on recreation, and, you know, personal care falls on PSWs and RPNs and MDs. And you know, there's probably maybe some opportunities here for us to try and make those barriers more flexible and to encourage a bit more crosstalk. But absolutely, within my own data, what I'm seeing is it's, you know, those types of meaningful engagement opportunities are sort of the purview of the rec folks.
I would add to that, and I'm not a labor relations specialist, but certainly we have similar issues in the US. And I know that the greenhouse project and having versatile workers had to not only negotiate with unions in some places, but also negotiate with regulators who have regulations against versatile staff. And even in New York, where we're allowed to have a greenhouse home, we're still supposed to do our cost reports, like how many hours of PSW did I do and how many hours of recreation did I do, even though I'm one person. So there's still a lot of barriers there. But I think it's important to, this advocacy is part of culture change. And I would also say that one thing that organizations can do is put it in the job description. The way to get around labor relations barriers is to make sure that you're hiring to the job that you want people to perform. And that way it's a lot harder to raise a fuss about that.
Thank you for that response. There is another great question from Kathleen. Outbreaks are not something unfamiliar to long-term care. Will the lessons learned from COVID carry forward to future outbreak situations when it comes to ensure residents are meaningfully engaged? And I would expand that question because it's along the question that I had is, there is a lot of decisions that we need to make at a post-pandemic. One is, how do we prepare for the next one? Which is what Kathleen is touching on, but also what are we keeping, which is kind of some of the points that you've made throughout the presentation, and how we're transforming ourselves moving forward.
So I would say, oh, sorry.
Go ahead, Kate.
I would say this is perfect timing because I just did a debriefing with a family member for one of our homes in Guelph this morning. So I would say that a lot of organizations, I think, will try and continue with many of the things that we've learned. As you can see from our data, and I'm sure from, you know, the experiences of those on the call, there has been so much hard work put into these new responses and new modifications. It would really be a shame if we lost all of that. Right. So absolutely learning for perhaps the next pandemic, or just in general for a regular flu outbreak, is key. But I also think a lot of the programming that has been moved online can be beneficial even if there's no outbreak, or even if there isn't a pandemic. So I have a participant's family member who lives in Ottawa, and they're able to now do virtual music therapy with dad every week. That was never offered to them before the pandemic, but now they have that opportunity to connect with them in a really special way with a trained clinician there on the call with them. And why would we let that go after the pandemic? You know, they're not going to drive every week 5 hours from Ottawa to Guelph to visit with dad and do that. It's not possible. So why not offer this? Our intergenerational music therapy we do with children as young as 3 months up to 4 years. Our attendance when we did this in November and December was nearly 100% because it was virtual. You don't have to worry about like nap schedules and there's a snowstorm and the baby needs a diaper change and now you're too late for the program. You just turn on Zoom. So I really hope that a lot of what we've learned and a lot of that, you know, individual personalized programming that's been created for people is something that we continue even when this is all done.
Yeah, I'm also very hopeful, Kate. I love all the points you made, and I would say that I've been doing a lot of webinars and team meetings over online, since I haven't been able to go anywhere. And one of the messages I've been trying to share is that this is a really challenging time, but there is learning every day in what we're doing. And if we can engage people, and if we can understand the needs of people with dementia, if we can shift our operations in such a drastic time, then we should be able to take it forward and be even more successful. And as far as the material that I was sharing at the beginning, I think there's a lot of direction as to what we need to start doing to prepare for this pandemic. And certainly from the infection control and prevention standpoint, there's plenty there. But as I said, there are many other issues. And just like Kate has found the learning curve with technology, there's been a learning curve when they've had the cohort staff and they've understood that consistent assignments actually are a good thing. They've had to engage people more individually and less in large group rec therapy, and they've understood how to do that, and they've seen the value of that. So we're already starting to appreciate how some of the things we've been talking about are really helpful. And I think hopefully that will take it going forward. This is by far the worst outbreak of any kind we've had in my memory. And so I think if we can do it now, we ought to be able to do it when there's a flu outbreak or a little GI bug on one of the neighborhoods. That should be a cakewalk compared to what we've been doing for the past several months.
Go ahead,
Thank you
Stacey.
so much, Chair. Yeah, thank you. We've got about 2 minutes left. So I just wanted to take the time to say thank you for sharing your thoughts and experiences and for bringing us this really useful topic today. So thanks, Dr. Dupuis and Dr. Power. Really enjoyed it. And just to let everyone know that the recording will be on the CLRI website and it'll be on the BSO website as per usual. And we're going to be running some polls now just to get a sense of what the audience thinks. You'll be able to follow up with an evaluation survey. The email will be sent after rounds. And I just want to say thank you, everyone, for joining. Einat, any last words?
I think, okay, my screen jumped. No, just I'm joining the kind words to really thank Kate and both of you for a wonderful presentation and truly for an opportunity for all of us to stop for a second and reflect on this challenging time, but not just to dwell on how hard it is, but also see and recognize the opportunities that came from it. So really thank you for that.
It's a pleasure. Thanks for having us.
Thank you so much.
Thank you, everyone. Have a great summer. We will see you next month.
Okay. Bye now. Thank you,
Take
everybody.
care. Bye.